Hello, everybody. This is Ricardo. I'm the director of the Global Mental Health Group at King College, London. And I have spent the last sort of 30 years doing research on mental health in low and middle income countries. And and a few of those years actually testing interventions, and more recently carrying out some implementation studies. Nadine, over to you.
Hi, I'm Nadine. I'm a lecturer in Global Implementation Science at the Center for Implementation Science, and I've been working in global health for about 15 years. I did my MSc in epidemiology at LSHTM and my postdoc there, and now I'm at King's working with Ricardo, implementing a lot of global health, and not only global health, but global mental health interventions and evaluating the programs. So I guess that's who we are. Shall we start the presentation?
Yeah, go on.
Now, can everyone see that okay?
Nadine has set up her subtitles to help everyone. We can't figure out how to turn it off, so you're going to have all the subtitles. Okay, sorry.
So to give you a bit of background in the discipline of global mental health, it focuses on how we can improve mental health outcomes and ensure mental health equity for all, which is very similar to global health, which tries to ensure global health equity for all. And what we do is use innovative methods to implement care that is known to be effective in high-income countries within low-resource settings. So the research to implement evidence-based care in these settings is clearly more relevant than it is to high-income settings where the need is the greatest. So as an example, this perinatal depression is estimated to affect about 13% of women in the postpartum period in high-income countries and 20% of women in low and middle income countries. And there's also a skilled workforce to treat these medical conditions in these settings. Now, compounded, okay, first I'll discuss some examples, and Ricardo can add to this too. But much of the implementation research in global mental health tests novel approaches to generate resources. So whereas in high-income countries, the resources are all about context, and low and middle-income countries, the resources are the primary objective. How do we generate these resources? So one of the most commonly used approaches is task shifting with community health workers to deliver evidence-based counseling to improve common mental health disorders. So a few examples, most of which Ricardo's worked on. A cluster randomized trial in Goa, India, used lay health workers to deliver an evidence-based healthy active program that is a brief psychological intervention adapted from behavioral activation for severe depression. And results from this trial demonstrate significant improvements in depression and disability, as well as some other secondary outcomes. Some other examples are task shifting to deliver other types of counseling, including the Thinking Healthy program that is based also on behavioral activation, active listening, collaboration with family-guided discovery and homework. So there was a trial in Pakistan, adapted the Thinking Healthy program to treat perinatal depression using lay health workers, and the results from this trial also demonstrated significant improvements in perinatal depression in the experimental arm compared to the control arm. So Ricardo is going to talk a little bit later about the Friendship Bench that also uses lay health workers to deliver evidence-based counting that's based on problem-solving therapy. And he'll talk a little bit about that, more about that in detail with you later. But besides using a lot of the I guess the community health worker, there's a lot of technology that can be used to help implement these programs too, using mobile phone technology to send messages, and things like telemedicine too, to help educate and task shift from the higher cadre worker to the lower cadre worker. But despite all these effectiveness trials, there's a problem bringing it to scale. And Ricardo's going to talk to you about this later and give you 2 examples. So although some of the trials are quite methodologically rigorous, there is a need to improve the overall quality of cases. So in many examples, implementation researchers do not even recognize the fact that they're conducting implementation research. So there's many cluster randomized effectiveness trials that are actually implementation trials, and that they're testing the effectiveness of methods to implement evidence-based practice, but they're not accounting for context. They don't have a program theory. There's many examples. They don't even recognize the fact that they're using implementation strategies and label them as such. Instead, they're described as components of the interventions. So if you do a search in Google, complex cluster randomized trial, you get a lot of these trials. And I've given you one example here if you're interested, and you can look at it. It was just published in Trials Journal, and it was labeled as a phase 3 effectiveness trial, but essentially they're testing the effectiveness of many different components that are already part of the government policy. So some of this helps to explain problems as to why we can't bring things to scale. But now I will pass it over to Ricardo to talk to you and provide you 2 examples. Ricardo?
Yeah, sure. Would you have to move the slides on, or can I move the slides on myself? You probably have to do it because...
Okay, that's fine.
Yeah? Okay. Well, essentially, Nadine has set the scene. So I want to just very briefly cover, one of the key, what I will call contextual issues that is common. There, it's needless to say, low and middle income countries, which represent 90% of the world's population, are very diverse. But they have one thing which is common, and it's not uncommon in high income countries, which is the lack of resources. And then, give you a couple of examples. Zimbabwe, use Zimbabwe as an example of one of the re-aim indicators, the implementation, and then the example of Chile to talk about maintenance or sustainability. Can we have the next one, please? So just to sort of set the scene and just tell you that everywhere you go, mental health, it's a major issue, but the level of investment on mental health is very low. And that happens in high income countries as well as in low income countries. Of course, it is a lot more pronounced in low income countries, as you can see on this graph. Next one, please.
Oh.
Thank you. If there is one resource that is really, really, really essential in mental health, it's the human resource, because a lot of services in mental health depend on people delivering, providers. And what you can see in here is not really important. What it is important is what you cannot see. And what you cannot see is that if you look at low-income countries, the darker bars, they're virtually absent, especially for the more specialized resources, human resources like psychiatrists, and also for other less specialized, but not as pronounced as for the more specialized. So essentially, in low and middle income countries, there are virtually very few, and in some countries, virtually no psychiatry. Can we see the next one, please? Now, if you can press again, just to highlight something. This is Zimbabwe. No, it jumped. Can we go back? Can we go back? Yes, thank you. There was something that went over psychiatrists per million. And essentially it was sort of showing that there is less than one psychiatrist per million. This example in many countries around the world, especially African countries, it's similar. So there are virtually no psychiatrists. So, can we have a world, can we deliver mental health service with no psychiatrists? Well, it's a reality. We have to. Next one. So this is the example of the friendship bench in Zimbabwe. In the absence of specialized mental health resources, such as psychiatry, what the strategy that we've adopted is what we call task shifting, which is no other thing, just simply transferring responsibilities to people who are, to health workers who are not so specialized. And that's what we did in the friendship bench, which is a study which is led by Dixon Chibanda in Zimbabwe. What we tested on a randomized controlled trial, the reference at the bottom, is that what can you achieve in terms of clinical outcomes if you introduce a lay health worker sitting on a bench and providing some level of counseling. And what you see in here, that, you know, on the left-hand side, we use a Zimbabwean developed way of measuring the SSQ, and on the right-hand side is the internationally known PHQ-9 score. And what you can see is that the intervention group is the gray bar. It has disappeared from the legend there, sorry about that. But what you can see is the difference between the intervention and control group is massive at 3 months and even more so at 6 months. So essentially, you know, it seems that, that introducing this person who was providing counseling and sitting on a bench outside the clinics seems to have been quite an effective way of reducing depressive symptoms. Can we move on to the next one? So that led us to think about, you know, why don't we scale up this? And initially, Dixon was able to persuade the government of Harare to expand the services to 36 clinics as a minimum. And so they did so. And then at the moment, we are undertaking a study of the implementation of the friendship bench in Zimbabwe. And I can share with you some of the preliminary lessons that we are getting. Now, we know that the friendship bench is happening, but there is massive variability from clinic to clinic. Reach, as an indicator of re-aim, is unknown because we don't really know how much of the problem is there on the populations. But if we are guided by the demand for this service, it seems to be good. The effectiveness of this, at least in clinical terms, is also fairly unknown because the information systems are not good enough to monitor the situation. As far as the fidelity and to what extent these health workers are actually delivering the service as intended, there is a lot of variability we're discovering on this. And one of the things that we have seen is that good supervision, which is essential to monitor what is going on and rectify things if they depart from what it was intended, seems to be more of an aspiration than an actual reality. The sustainability is and remains uncertain, as most things that you try to develop in low and middle income countries. And now with the COVID-19 epidemic, things are even more difficult to predict. One thing that we do know is that when you have some local champion, as it is the case with Ruth Berhey and Dixon Chibanda there, it's more likely that things can keep on going. One of the things that has been important for us to realize is that the official budget that the government of Harare offered to put forward for this, it was a small, and you know, dare to say, quite unclear, and it was never ring-fenced. That is something that I want to highlight because of the difference with the next example I'll give you. And finally, to say that the friendship bench is not clearly embedded within the system. And that, in terms of implementation, can be a potentially very difficult challenge to overcome. Can I have the next one, please?
Whoops, yeah.
Yeah. So this is what we did in Chile, similar kind of thing. The whole story started with a randomized controlled trial to try to test efficacy or effectiveness, more like in the friendship bench of the intervention. Next one, please. So the whole idea was, an intervention to try to improve. I didn't put in there, but that's okay. I'll tell you what it is. We tried it. This was the very first one of these sort of trial to try to improve the depression treatment in low and middle income countries. And it was a tremendous success, actually. At 3 and 6 months, the difference between the usual care and this improved program were massive. So that created a lot of momentum for us and for the people in Chile and in other parts of the world to try to replicate and do similar kind of things. Now, in Chile, for a number of reasons, the government was persuaded and scaled up the program. Since 2005, it became a national depression treatment program, and it has been increasing ever since then. And today, I can say that there are about 400,000 people being treated within this program and another program that was added for people with depression. Can we have the next one? Now, we did a qualitative study alongside this one after we had finished our study and the implementation was in full force to try to understand, why was it implemented? What were the key things for the implementation? And I'm not going to share with you all the whole thing. It's published, but there are 3 things that I wanted to share. The number one that I think it was an important thing, it was to form strong alliances. And in this particular case, the alliance was with the primary care unit. The actual program was given to the primary care sector and they took it as their own. And the primary care department within the ministry was very strong. That gave it a lot of strength to the program to be maintained over time. Can we have the next one, please? And the second thing I wanted to say that, which is the thing that we didn't do in Zimbabwe, or we haven't been able to do it so far in a good way, is what I call the institutionalization. Institutionalizing, making a program part of the official story, it is essential to ensure sustainability. Once it has become part of the thing, it is virtually, I wouldn't say impossible, but it is very difficult to, it's more difficult to dismantle things than to add things. And that was one of the things that, it was done in there, and I think it's a key thing for the sustainability of longer than 10 years of this program. And finally, ring fencing. All the resources that were required for this program were ring fenced, and they became part of the official paperwork of the ministry. So nobody could touch that money. Next one, I think that's the final one. Yeah, I'm not going to talk about this. It's about equity. I'll leave it because we come to our time. We're open for questions now.
I think we have one person listening. Would anyone like to ask a question?
You have 7 people listening, not 1 person.
Where can I see the questions?
Are there any questions? I do not see any.
Everyone, you can turn on your video because it's quite a small session. So don't be shy, because it's nice for Nadine and Ricardo to see your faces.
If you don't have any question, I can tell you about the last slide then.
Perfect.
It's up to you. You tell me what am I supposed to do? You're the boss.
Talk about the last slide. That's quite
Go
an
ahead.
interesting finding.
Yeah.
Or I can ask a question to, can I ask a question to Nadine?
Of course you can.
Well, I mean, I must declare that I'm not an implementologist. I'm learning as I go. I think, my journey, I was an epidemiologist, and my interest was to sort of, I discovered that there was a tremendous need and it was not being met. So I became involved in trying to develop interventions and trying to see whether or not we could make a difference. And once we began to do that thing and we discovered that certain things were actually effective, the next step was, well, obviously we need to scale up these things so more people have access to them.
Mm.
And that's how I became interested in implementation. But I have found it difficult to navigate the implementation seas. And my colleagues that I work with on some of these things also find it difficult. And one of the things is to do with the large number of frameworks, implementation frameworks that are available, the complexity of some of these things, the complexity of some of the concepts involved. It's just sometimes it becomes almost impossible to navigate the thing unless you have a captain like Nadine next to you. What's your reaction, Nadine?
I think your reaction is something that we get all the time, and you might have seen with the recent implementation science protocol paper for the health system strengthening program that we have in sub-Saharan Africa, that I find a lot of people find it difficult to conceptualize it and put it all together. And the same for a lot of the implementation science students done with MSc, they really struggle to put it all together. I mean, it makes perfect sense to me, but it's how can I get this across better to other people? And that's something I'm trying to think of a few publications that we want to get out there to really help people understand it. It's not about all the different frameworks. It's about, helping you select some parts of context that are relevant to your setting and choosing a framework that's relevant to that. So for instance, with our asset program, we looked at, external context is highly relevant, but also the context within the health facilities is highly relevant. And so is behavior. Changing behavior is one of the hardest things we can do. So to help people with that, I just selected a few different frameworks, asked them to use them to help to identify some determinants that might be influencing the delivery of evidence-based practice, and then select different, implementation strategies, health system strengthening interventions, and theorize how those will actually play out in practice. But I agree, there's a lot of frameworks, and according to Nick Savallis, if you discover a framework and get it published, you're set for life. I don't know about that, but I don't find it overwhelming, but many people do. I think, you just have to talk to an expert really and figure what would be the best one for you, but it shouldn't be the all guiding thing that you do within your program. If you see what I mean, if you do just look at a framework and say, oh, it's going to be a big success, that's not the case. It can help you.
I'll tell you what my reaction to that is, having done a few of these things now.
Yeah.
I've discussed this with you and Nick before. And I think, implementation for a lot of people is seen as a sequential step at the end of a journey. When you've proven the effectiveness of something. And that, I think, is a massive mistake.
Yeah.
I think implementation should be seen as the entire journey,
Yeah.
From the design, you should think about issues that you can foresee, you know, that, like sort of I said, you know, the lack of specialized human resources in low and middle income countries when it comes to mental health, that is clear, crystal clear. Nobody needs, you know, any science to know that.
Yeah, absolutely.
And then if you're going to test something, number one thing is to think, you know, what is the likely context here? Before, when you're at the stage of design, you have to design things that will stand the test of implementation in the end. Otherwise, you're just wasting the money.
Oh, absolutely. You have to look at things like acceptability. Is that going to work? Do people like it? If they don't like it, it's just not going to work. So you do have to look at that, and it's so important. But with one of your, I guess, Ricardo, that really amazing grant application you put through that I absolutely loved, and it was looking a lot of co-design and really, really thinking things through before, you know, you actually decided to even start implementing it, and put so much thought into that. I think you're right with that, and I think that's really what's needed most. And also looking at context, and there's different ways you can look at context. You can get some of these frameworks, yes, but you also need other methods too. And to just get a framework, I think, and just monitor it throughout the course of the implementation and evaluation, I think is a big problem. You need these experts like Jamie Murdoch, who I've been in touch with, because we've been discussing context and how do we conceptualize this and really bring it together and evaluate it, because it changes constantly. And if you're not constantly looking at this and looking at how it influences the different implementation strategies and the implementation outcomes and the whole process, you know, you can get into trouble with that. So it's just one of the things that's so interesting about implementation research and science is it's an incredibly complex phenomena. So getting your head around it and really understanding how you can get these in and sustained, especially in low and middle income countries where the external context and resources are so important.